Welcome back to our Unclenched podcast. Today we're going to talk to Dr. Stephen Deal, Little Rock, Arkansas, as my daughter calls it, Arkansas, which is kind of what it should be. And we're going to talk about facial growth and issues that may cause TMD and a lot more. And at the end of the podcast, we're going to answer a couple questions from you guys, the listeners. But before we get started, I got to get caught up with my girl, Priya. Priya, what's going on? What's
Hey.
happening?
Hey, so I was gonna tell you about a patient that sort of stood out to me this past week. But before we do that, I did want to do a little highlight on Little Rock, Arkansas. So
Oh,
it is like, yeah, so they talk about it in this movie called Gentlemen Prefer Blondes. It's an old classic, Marilyn Monroe, and they sing about Little Rock, Arkansas. So if
are
any of
you
you
going to
guys have
sing
seen that,
for us? You
no,
going to sing?
absolutely not. Your ears will die if I sing for you. If I could sing, I would be singing off the rooftops. Like, I am not shy, so I would do it, but I cannot. But,
Okay.
Gentlemen Prefer Blondes is such a good movie, and they talk about Little Rock, so I just wanted to, like, highlight that real quick.
Okay, got it.
A patient that stood out to me, in the past few weeks, her name is Jeanette. Her number one complaint was her bite felt off and her front teeth were scraping against each other and chipping. Like as she spoke, as she chewed, she had jaw pain on the left side, headaches, migraines, neck pain, popping and crackling noises, and her jaw locked closed a few times. Like it got stuck where she could barely open. And she started treatment with me. And through treatment, like we resolved everything. So I actually just released her from active treatment with instructions to continue wearing the nighttime orthotic. And she's doing so well and she's so happy. So, like, she was someone that stood out to me. And in the past uh, few weeks, we bought a minivan. So I caved.
Oh, I bet our guest drives a minivan.
Oh my gosh. So I told my husband, I was like, "I will never drive a minivan," and now we just bought one. And not because, like, there's anything wrong with them, but it's just, like, I just feel like I've, like, given up. Like, I'm just
Yeah,
like, "Okay." Like, I'm the soccer mom, I'm the all the things that go along with that. But
yeah.
my father lives with us, and we have a 4Runner, so he sits in the front in the passenger seat, my husband drives, and then I am crammed between the 2 kiddos' car seats. And
Mhm,
my kids are tiny. Like,
mhm.
they will be, like, 45 years old before they are the proper weight limit to, like, move out of booster seats. I'm just like, "I'm done." Like, I can't, and I'm not a big person, but, like, the 4Runner isn't, like, huge in the back at all. So I'm, like, crammed between these car seats. The kids are fighting, they're throwing stuff at each other, and I'm like, I am done. Like, I can't sit back here anymore. When we park, I have to wait for, like, my husband to unlock because the children locks, whatever they're called, are on. So I have to, like, I can't. So I just said, "This is a big first world problem." I can admit that.
Yeah, yeah,
So I
right?
Can we just do something about it? So he was like, "Okay, we can get a minivan."
Yeah,
So we got
that's
a Honda
funny.
Odyssey, and we're so excited about it, but what's so funny is that, like, we have a lot of nieces, nephews, whatever, they live in Orange County. So, like, our nephews that like, boys are drawn to cars. Like, I hate to just say that, but I see it all the time, right? So, like, our nephews that are down there, they, like, know, like, BMW, they know Ferraris, they know
Sure.
Aston Martins, they know Mercedes. My kids are like, Hyundai, Honda, Subaru, Toyota. It's just
Yeah,
so funny, like, the difference, but anyway, so that's what I've been up to, but what about you? Like, what's going on in your life? Is there a patient that stands out? I
yeah.
wanna hear it all.
Well, the best thing going on in my life is actually what's going on with my youngest daughter. She started the first day of her last year of dental school. Woo, woo.
Woot
So
woot.
we're all excited about that, and she's really excited. So yeah, it's fun. But about your minivan, I saw a bumper sticker on a minivan that was quote, "I'll never drive a minivan." Unquote, and I died laughing because so many of my friends have said that, but always ended up getting one because it's easy to
I'm
stack
writing it
everybody
down
in.
because 'cause I'm getting
Right.
that bumper sticker.
There you go. There you go. But I had a patient, and this is going to kind of bring me in with our guest, Stephen Deal. I had a patient that I saw in 2011, and I put her in a fixed orthotic. I mean, not a fixed, a removable orthotic, like what you do, and she's been good. And it wore down, obviously, and then it broke, and then she lost it, and then she finally got around because her symptoms all came back, and she finally got around to coming to see me. And now she's 33 years old, a mom of two, and she is ready to go into braces that I learned from Dr. Deal. And Steve's on. So hi, Steve. How you doing?
I
Hello,
am great.
Steve.
How are you ladies?
Oh, we're good. We're
Good
good.
to see
We're
both
just
of you.
loving life.
We're
Loving
loving
life.
life.
Thank you so much for having me today.
Thank you for being here. And I just have to jump in first because I met you last year at
Right,
my first ICMO conference. I was finally able to go.
right.
And you were lecturing, and it blew my mind, and I asked you, like, 5 billion questions. I was sitting in the front row with Dr. Alex, and I was like, "Oh my god, I have so many questions." Da, 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 da. So, reading your bio, you graduated dental school, and like all of us, we started out practicing exactly what we were taught because that's what
Correct.
you do. So, how did you shift from graduating with a general dentist background and that knowledge to facial growth, orthodontics, dentofacial orthopedics? We're not really taught this in dental school, and I really want to send my husband to your courses for my daughter. So I know I've talked to you a lot about that, but
Right.
anyways, yes, go ahead.
Well, like all of us, like you said, we get out and we start doing general dentistry. And pretty quickly, after just a couple of years, I started noticing that I would send my patients over to the orthodontist and they would, well, just like I was taught in school, how to fill out a referral form, right? And send it
Yeah,
over to the orthodontist. That was
sure.
about all you learn in ortho. But they would come back, and I was not extremely happy with the results. I would send them over with crooked teeth, and they would come back with straight teeth, but their faces were dished in. There was they still had problems. They were having relapse. They were having a lot of things, and so um, I really when I had kids, I really started thinking, I want the best that I can possibly give them. So I really started on a track about 2000. I graduated in 2003. And so in 2005, I started researching and trying to do orthodontics. And so I took almost every course that you could imagine that was available. Every practitioner that was teaching ortho, I was going and listening and learning. And I did straight wire technique for
Mm-hmm.
a few years.
Mm-hmm.
At that point, I actually met Dr. Steve Galella, Dr. Chris Simmons, some of my other mentors like Sam Beavers, and they, Dr. Beavers was a practitioner here in Little Rock. He's a TMJ practitioner, and he was excellent and one of my first mentors. And I really got into this because I wanted to treat my kids. And so when I started looking at straight wire technique and started seeing the problems, I really was looking for a better way. And really, when we started talking about facial aesthetics and TMJ, sleep apnea, those things I was still seeing, and I knew that we could do a better job. So I was seeking it out. So that's really how I started, and then it just really went from there. It became the focus of my practice because no one else was talking about this. So.
Mm-hmm. So you are a fellow of the International Association of
Yeah.
Orthodontics
Yes.
and American Orthodontic Society, and you're
That's correct.
not an orthodontist.
No, no,
Hmm.
no. I'm not an orthodontist, and I'm proud to say I'm not an orthodontist. But I do a lot of braces, and so when you look at across the U.S., you see about 330 million people, and there's less than 100,000 orthodontists. And so
Wow.
when we look at that, there's too many people to see. When you talk about the study showing 85% of the population is jaw deficient and has crooked teeth, And so they have problems that
Mm.
need addressed. And so you see the majority of orthodontics done, whether it's Invisalign, whether it's straight wire, whether it's whatever technique, the majority is done by general dentists. And so the biggest general dental orthodontic society is the International Association for Orthodontics, the
Oh,
IAO.
okay.
And the next biggest is the American Orthodontic Society. I'm a fellow of both of those. I've been with the American Orthodontic Society since 2006, with the IAO since about 2007. So long time.
Wow. Wow. What did you have to do to get your fellowship?
Well, it's quite rigorous. You have to have about 700 hours of relevant um, continuing education, and then
Wow.
you have to pass a exam that encompasses all sorts of different techniques in ortho, a very broad a very broad uh, 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 education in orthodontics, and then you have to defend three of your cases. And
Wow.
so right, it is it's pretty rigorous. So
Wow. Wow.
Wow. So you can be a fellow of the International Association for Orthodontics and the American Orthodontic Society and not be an orthodontist.
that's correct. There is no, the only way to become an orthodontist is to go with a university based program,
Yeah,
and
for
it's
the
it's
program.
a 2 to 3 year program. Yeah,
Wow.
Sure. And I know when I took one of your classes, you stated like, I don't know, it was over 60% of general dentists do orthodontics of some type. And
yeah.
it's probably higher now because of Invisalign.
Right, right. And it used to it was a over 50% were doing some form of minor tooth movement, but then Invisalign came along and they really took the message to the public, which was a little bit different. And so dentists got into it because their patients were looking for it. But
Mhm.
as we all know on this podcast, that um, Invisalign and clear retainers can enter in some problems that we have to deal with if not done
Mhm.
properly. And so there is a lot of orthodontics done by general practitioners. Over 50% of your, I bet it's north of 70 now. I haven't seen a statistic, but I bet it's north of 75% of dentists do orthodontics now due to clear aligners.
Sure.
Yeah, a lot
Sure.
of them do. Yeah.
So let's talk about facial growth and development. So let's just
Okay.
start at like the basic. Okay. You
Okay.
have a baby. You don't, but Priya and I have. So you have a baby, and what should a new mom that just has this new baby in life look for to know like, okay, is this baby going to develop okay?
Okay, so if we're going to talk about facial growth, you really need to start with like what is the prevalence in the population of what we would call altered growth or incorrect, if you would like to say it, deficient, however you would like to say it. Deficient growth happens in 85% of the population. That is a study from the 1980s that was actually done by a orthodontist at the University of Michigan, James McNamara. And that study was backed up with two other studies that found the same thing. North of 85% of the population is mid-face deficient in their jaw structure. Okay. So we
That's a
know that
lot.
this, yes, it's a huge amount of patients. And so almost everybody, right? And
Yeah.
I don't think, and now that study was done 40 years ago. So it's not like it's gotten better. It's probably gotten worse. And so, but we know for a fact that at least 85% of the population, and this stems from two things really. Okay. One is the soft diet. All right. And the other is how we breathe, whether it's nasal versus oral breathing, mouth breathing. You add in the fact that we wean our children early, and we have an issue with the growth of the craniofacial complex, the jaws, the face.
Mhm.
And so if you're talking about a new mother, okay, the first
Mhm.
thing that you would talk about is you breastfeed as long as you can,
Ugh.
as long This is right. This is almost taboo for a man to talk about because I have no experience in this realm, right? So
Yeah.
for me to say it, it's much easier said than done. However, if you're looking for what you can do to better your child's life, it's going to be to breastfeed for as long as possible. We are the only mammal in the animal kingdom that weans our babies before the eruption of the first deciduous molar. So it would be almost taboo, like I said, for a woman to do that in this day and age, because you're running up on 2 years of age. Yes. So that would be the first thing. And the reason that's so important is because the greatest percentage of growth of the maxilla, which is really our main key, is from the 0 to 2 years old. That is the greatest growth spurt that we have. So if we miss this, we're going to be behind the 8 ball to begin with. Okay, we're going to be already behind. So really concentrating on not early weaning, going as long as you can breastfeed. And then if you can't breastfeed any longer, it really needs to be one of these anatomical bottles to really help make the baby work those jaws for the milk. So early weaning is a problem. All right.
Mhm.
So the next thing, right, would be a hard diet. I have a friend that calls it the Gerber generation. We should really never give our kids that mushy food. They need to go to a textured
Wow.
food, because a hard diet is how we really get the deficient jaw structure. Back in the
Yeah.
day, our ancestors, they ate something really hard, like roots and tubers. Our teeth are made to eat something really hard. But nowadays, we eat something really soft, like Little Debbie snake cakes and hamburgers, right? And so instead of using our jaws and our muscles to develop the bone, we eat soft food. This is why everybody's teeth are crooked. We don't develop the bone enough to house all the teeth. So they have to come in crooked and turned and twisted. So hard diet, that's a big problem. There's hardly anything in the grocery store that's hard enough, but we for sure don't want to be giving them Gerber and and mushy food, pureed green beans. There's no reason for that.
Well, then
Something
the
hard.
parent's gonna say they're gonna choke or they're not
Yeah,
gonna.
that no, that we didn't choke. We're still here, right?
Right,
For thousands of years, we
right,
didn't have Gerber baby food, right?
right,
And we
right.
still make it, right? So they're not going to choke.
Okay. What about when they do start to feed their baby mushy food? What about how they feed it or the swallow or anything like that?
That's a good question. There was a study done by one of our friends, Alex, Dr. Bromwich, and where he took some babies, and you know how normally what you do with babies is you take the Gerber and you'll take the spoonful, you'll put it in, they'll spit about half of it out. And
Right.
what do moms do? They take the spoon, take it off the mouth, take it off the cheeks, and stick it right back in, right?
Correct.
Well, this is really not the best way to do this, okay? Because when you're breastfeeding, what do you do to the baby to indicate it's time to latch on? You stroke their cheek, right? So you'll stroke the cheek and hold them near the breast. Now they understand it's time to latch on and it's time to eat.
Right.
Well, if you think about it, when you're sticking this baby food in, they're spitting it out, you're cleaning it up off their cheek and then sticking it right back in. You're teaching that baby not to have the proper swallow. Keep that infantile swallow, right?
Mhm. Mhm.
And so what Dr. Bromwich did was he sat the babies down, he fed them, let them get it all over them. They didn't eat but about a quarter of the food. Then he took a cloth and just wiped it off their face. Sat them in the floor. Of course, 20 minutes later, because they haven't eaten hardly anything, they're
Yeah.
hungry again. Sets
Yeah.
them in the chair, does the same thing. Doesn't just feeds it in the mouth, doesn't touch it. And then when it's all said and done, he cleans up the mess and sets them in the floor. In one day, these babies, compared to the control group, these babies had a proper swallow in one day.
That's
So
huge.
So
That's
describe
huge.
a proper
Yes.
swallow. Where should the tongue be? I know Priya
Yeah.
always does this, but where should the tongue be with your proper swallow?
When you're talking about a swallow, whether just proper tongue position, really.
Mhm.
When you are at rest or you're beginning your swallow, your tip of your tongue should touch the N spot where you pronounce the letter N.
And
N. So you pronounce the letter N. That spot is where your tongue should rest when you're at rest. And right before you swallow, the tongue should touch that spot, teeth should come together, and you should swallow front to back in one motion. The
Mhm.
incorrect swallow is normally where the middle of the tongue is what elevates to the top of the mouth. You cut the bolus of food in half, you swallow the back half, and then you chew the rest of the front half, and then you swallow again. This is an incorrect swallow, and the two motions are greatly different when we're talking about muscle activity and how that affects the myofunctional condition of the patient.
well, I have two kids, not newborns, but they're a little older. They're 5 and
Right,
7 now. And I saw you
right,
when you spoke at ICMO. I had a gazillion questions for you, and I was texting you, and
right.
then things sort of got busy during the holidays,
Oh
etc.
yeah.
But it really got my wheels turning on what I see at home with my kids. So, what do you recommend that I should be doing for them or looking for like other moms that notice that there's some issues going on?
Well, if when we're talking about my treatment and my demographic of patients, right? I say that I have three groups of patients. I've got the 0 to 4, and that I don't see a ton of those. Okay.
Yeah.
There's the 5 to 9, and I do see a ton of those. That's my
Mhm.
favorite group. And then there's the north of 10. Okay. Those basically what I consider compromised patients when we're talking about growth and development. Okay.
Mhm.
So 5 to 9 is my favorite treatment time. And what you're looking for all the indications of improper growth and poor myofunctional condition of the patient. So if we're looking at talking about what are some indicators that you could look for easily with improper growth and development, one would be a long lower facial height
Mhm.
compared to your upper face to your lower face.
Mhm.
Okay, long lower facial height indicates that they're open mouth posture and they're growing in a clockwise fashion.
Okay.
Now, another indicator is lowered cants of the eyes. The corners of the eyes are turned down. The mid face extends from the lower of the orbit all the way to the maxilla. Okay, so lower the orbit to the maxilla. So if this is not developed properly, you'll see downturned cants of the eyes.
Mm.
That's another indication. When you see white underneath the eyeball, okay, that's
Mhm.
underdeveloped orbit. Another is the cheek line, which I teach in my classes. Um, when you are talking about the cheek line, what you're talking about is a line that runs from tangent from the lower border of the eye down to the soft tissue portion of the cheek, like
Mhm.
this, like
Yep.
this. Okay.
Mhm.
And what you're looking for is for that line to be parallel to the bridge of the nose. If it's not, that's an indication that the cheeks are too far back, the midface is underdeveloped.
Mhm.
When you're
Okay.
looking at the arch of teeth, if they're narrow, they have black triangles where the buccal corridors are not filled out. They are
Mhm.
narrow.
Yeah.
Okay, like more of an A-frame shaped arch of teeth instead of a nice horseshoe. Right. Those are all some of the things that you can look for. There are other things like I talk about that I get into more advanced things like cranial strain and
Mhm.
their bite and whatnot. And so
Yeah.
there's quite a few things, but those are some easy indicators.
That's good to know. And
Yes,
and
flat face is a big one. So
okay. Okay. So I did start my daughter, she's 7, on a myo brace and myofunctional therapy. How, as a parent, would I know that that's working? Like, what can I look for to know that we're moving in the right direction?
well, if you're talking about lay people, how would they know
Yes.
like
Mhm.
how
Yeah.
how it's working? Right. You're going to be looking for changes in what they're doing with their myofunction is really what I would be keying on for moms. Okay, well, chronic open mouth posture, is that getting better?
Okay.
Right. Okay. If you're talking about even some development of their cheeks, even some widening of their arches, because if the tongue is in the right position, you're going to start seeing changes to the dentition.
Yeah.
That's correct. You're going to start seeing changes to the oral cavity. They will get visibly wider. Their cheeks will look different. Their posture of their jaw will look different. They will not have this long lower facial height. It'll start
Yes.
looking more like a squared off L. Okay.
Yeah.
And so a lot of these things, it's not going to be overnight, and it will be subtle,
Yeah.
but they will be able to see it if they're paying attention.
Well, I wanted to show you real quick a picture of the kids. So we were in London a few weeks ago. I've never been there before. It was amazing. But they
Oh,
fell
awesome.
asleep on a tour. We were on a bus going to Stonehenge, and it was a long drive. This was them. Look at their lip seal.
Look at that.
Look at that. And my daughter is so far retruded, and their
Yes.
lips are sealed. And that is because they're sleeping with the myo brace. And so my son has woken up multiple nights with the myo brace, like multiple mornings with the myo brace still in his mouth. It's not an issue for him. My daughter's had a really hard time because she's so far set back. So it was really neat to see them napping with good oral posture there.
There you
I don't know
go.
where their tongue is, but I know their lips are together. I'll take it.
Well, if the lips are together, the tongue has a better chance of being at the top of the mouth,
Much better.
and you know they're nasal breathing, so the lower jaw is in a more forward position. So this is good. I will tell you, there's a study from last year in 2023, November 2023, that came out, and it showed where if you are lip taping, it's a 50. If you just by simply lip taping, you can have a 50% decrease in sleep disordered breathing.
That's huge.
Right. That is huge. So everybody, we talk about lip tape anymore, and a lot of mothers are skeptical, but we definitely have some backup saying that it is a good thing. So
Oh, I was lip taping them before I started them on the myo brace too. Like
I lip tape my kids when they walked in the door for 10 years. So yes, that, and I would have them chewing mastic gum. I did that a lot too.
yeah, we got the gum after your
Yeah.
lecture. My kids hate it. They're
Oh,
like,
yeah.
this is awful.
It is, but you
And you're
take
like,
two pieces.
"Just
You take
chew
two
it."
pieces of you take 2 pieces of mastic gum with a piece of regular sugar-free something they like to chew, and put it together.
Oh,
It's
that's a
much
good
better.
idea. Okay,
Yeah,
okay.
it's much better.
I should do that. I'm like, I'll just buy you a toy if you just chew this.
Right. Just chew it. Yeah.
Yeah. I got to tell you something funny about lip taping. So I lip tape because sometimes I purr at night. It's not
Oh,
snoring.
yeah. Right. It's not snoring. Yes,
No,
of course.
right.
Snoring.
So
It's purring.
when I lip tape, I'm much better. So when I do it, I have to do it when my husband doesn't see me because he will not let me lip tape. He's like, I'm going to turn over and you're going to be blue one morning. I'm like, I am not. That's the whole point.
Well, if you're lip taping just up and down, not side to side, just up and down, you can still sneaky breathe, as they call it. So,
Sure.
right, it's fine.
Yeah,
I would say don't tell patients to go side to side because that's probably a medical legal
right. And don't
liability.
use duct
But
tape.
up and down,
That's-
yeah, right, and up and down's not going to hurt anybody, I don't think.
Yeah. So Stephen, I've attended a lot of your lectures. I've come to your place in Little Rock just
Right.
there a couple weeks ago, a month ago or so, for
Right.
your Real Deal Study Club, which is awesome. And I've
Thank
learned a lot. And
it's called, hold on. It's called The Real Deal.
well, that's what we decided to name
That
it because
is
it is the real deal.
So good. That is so good. Okay, my last name is Mystery, and I'm like trying to like find a good way to market
Right.
that. Real
Right.
deal, you win. You win.
He
You
does.
win.
I mean, not a whole lot of deals around, so you got to use
Dude,
it, right?
you
it
gotta
really
be the
is.
real deal.
It really is the real deal because
wait.
you get to the nuts and bolts of things. When Steve explains a lot of stuff, just like he's doing now, you're like, huh, makes sense.
Totally.
But so many people in the world of dentistry just think differently and practice differently, and that's okay. But it's nice to open up your eyes to another way that you may get better results, or you'll get people to look and grow better. And you've talked about epigenetics, and this is really interesting. So can you explain, because we have listeners that are patients, and we have listeners that are students or doctors,
Okay.
but can you kind of dumb down what epigenetics is?
Sure, sure. So everyone, all of us are born with a genetic potential, right? For whatever, for the way
Mhm.
that our face is going to grow. Let's just say for the size of our jaws, for the shape of our face. And that is a potential is there for based on our genetics. But then there is the epigenetic influence on our genes, which is the environment, what is happening to us that may change the way that we grow, the way that we adapt, actually, to what's going on in the environment is what I'm talking about. So really, the adaptation of whatever. Maybe it's soft food. Maybe it's pollution. Maybe it's the fact that we have keep a snot nose because we have cats in the house. I don't know what it is, but that's all the environmental influence on what how our genes were going to we had a perfect world, how they were going to um, end up, how we were going to end up. The environmental influence changes that. That's epigenetics.
Yeah. And we have so many environmental things, like you're saying, the allergens. So many people have these allergies. Like when I was growing up, nobody had a nut allergy.
No,
So when you're allergic and you're breathing through your mouth, your tongue's not in the right place, and then everything kind of falls to hell in a handbasket. Well,
yes.
something like that.
I tend to think that really the nutrition these days has a lot to do with it. That we are not properly um, we're over we're overnourished with poor food. How about that?
Hmm.
Okay, so the quality, what's in the food, there's very little nutrients in it. It's just high calorie, and so there's a lot of great things going on in functional medicine right now, and especially talking about nutrition.
Yeah.
So I guess where is the growth occurring? Like when you treat a patient like with the real deal method, I love this. Where is the growth occurring?
When you're talking about the upper and lower jaws, okay, when the man who wrote the book on craniofacial growth and development was Don Enloe. Okay, and so one of Enloe's quotes is, "If you change one bone in the craniofacial architecture, you change all the bones." So to say where are we growing, it would be a long conversation. But if you're talking about the growth centers for the upper and lower jaws, it would be in the upper. It would be the maxillary tuberosity, which is just posterior, just behind the last tooth, right? Yes. Now, when we're talking about the lower, it's the posterior border of the ramus, the posterior border of the jawbone. That's where that's where the growth is occurring. Now, then you have the condyle, you have the neck of the condyle, which are growth sites throughout your entire life. They can
Sure.
adapt, but the main growth is occurring in the posterior ramus in the lower.
Hmm.
That's interesting. I don't think I've ever heard that before. Like I have heard mostly the neck of the condyle, the condylar head. Like so. Wow. Yeah, I'm learning.
Well, we didn't learn that in school. Like what's so silly about our education, and this goes for all dental schools, not just one, is
Yeah.
that we don't learn the things that we, or I should say this, it's not reinforced what would be helpful in clinical practice versus
Mhm.
what is not helpful in
I
just
know.
information to know, right? So, like what I just said, there's very few dentists that can even tell you what a click pop is,
I know.
right? This is a problem. We need to understand what's going on with our growth and development.
Sure.
Yeah. So a lot of that too, when you talk about the click and the pop, it's all about you gotta get the diagnosis of what you're treating. And it's not just, so many times you hear patients that'll end up in our offices, oh, it's just a click and a pop. They said if it doesn't bother me, don't worry about it.
Right.
But we're a little bit different. So when you talk about the growth, Can you get this in adults? And is there a period of time that it's too late, that we can't achieve growth? Like you hit a time and you're like, oh,
Yeah.
can't do anything or can't change anything.
This is a question I get a lot on my socials, and people will say, "Can this be achieved in adults? This kind of growth? Will mewing help?" So I'd love to just get your thoughts on that.
Sure. So when you're talking about growth, okay,
Okay.
the definition of growth is displacement plus remodeling of the bone.
Okay.
Okay. So when we are in that north of 10, in my practice, I call it north of 10. That's the compromised patients. There's very little growth left. I say very little. When a patient is 10, 11, 12 years old, their head size is going to be in the 90th percentile of what it's going to be, 90% of what it's going to be when they're an adult. Okay. So there's not a whole lot of growth left. That's why I say they're a little bit compromised. Okay. Now you can have remodeling occur all the way through your life. Okay. So yes, to say that you can do something with these patients, yes, you can. You're not getting much growth in teenagers. Okay. Not a ton, right? And then in non-growers, you're not getting growth. You're getting remodeling of what they have, of the bone that they have, taking it and doing something different with it. So to say that you can grow in non-growers, that's not the case. You remodel the bone in non-growers.
Right. Because people will show up in my office when I do ortho and we're like, well, we need to, expand you a little bit or bring you forward some. Well, the orthodontists say, I'm too old. I can't do that. But and that's where I correct them and say, it's remodeling. It's not
That's right.
much expand. It's remodeling.
That's right. There's so many studies. I mean, it's one after the other. And Alex, you have access to all the research papers that I put in on in our Google Drive, and there's just one after the other showing that when you expand the upper arch, it helps in the nasal volume, in the oral nasal, in the oropharynx, and in the nasopharynx, and so it helps the airway. So there is no doubt that changes can be made as an adult. It's just not growth. You're not getting any additional growth of that because there's no displacement. It takes displacement plus remodeling to be growth. You only have remodeling in a non-grower.
Okay. So before you talked too about balanced growth. So what makes the balanced growth stable and things not to
Great question.
collapse? And what do you mean by balanced growth? Because I think it's so great. It's interesting.
Right. So like I said before, we have so many patients that are on this incorrect, imbalanced growth pattern, growth trajectory. Okay. And really what we're looking for is to move this back to normalcy, right? To a more balanced pattern. Now, what do I actually mean when I'm talking about an imbalanced growth pattern? When we're really talking about our realm, it's the upper jaw is growing too vertical. The lower jaw is responding to that. So it's the upper jaw that's growing too vertical. So when we're talking about a better, more balanced growth trajectory, it's the upper jaw moving more in a down and forward direction, okay? Displacing in a down and forward direction, not so much a vertical direction, not so much a down only. So that is a more balanced growth trajectory. And what really cements that, what really is the key to that, is what I call the big three, okay? And that is lips together, breathing through your nose, tongue the roof of your mouth. So those three things are really key to achieving your goal. And then we have to have that after we balance out get a more balanced growth trajectory. Okay. Because that's what has to change in order for there to be a adaptation of your body, a true change in what's going on. Because really, and Alex has heard me say this 100 times, the problem with traditional orthodontics and traditional treatment is the fact that patients come to you and they sit in your chair And their teeth are in that position for a reason. That is the adaptation of their body that allows them to breathe and chew the best.
Mm-hmm.
Right. So how did they get into that position? Okay. It's by their tongue posture. It's by their jaw posture. It's by the way they breathe. It's by their tongue position. It's all of these things, right? And so if you don't change the way that their teeth got into that position to begin with, then you don't have much of a chance of making it a balanced, stable situation after your treatment. They have to have the big three: nasal breathing, lips together, tongue in the roof of your mouth, no tongue ties, no tongue thrusts, no tongue problems, right? Proper swallowing, that also goes with tongue. And so they have to have this correct myofunctional condition in order to change and make a meaningful change to their condition.
Yes.
Yeah.
Well, I keep thinking about my child. She's 7, little girl. Her face doesn't look balanced. But what's interesting is she can really function without complaining of anything. I mean, once every 4 or 5 months, she'll say, "Mama, I have a headache. Can you give me a head massage?" And I do some cranial work and it goes away.
Sure. Yeah.
But like, what will this imbalanced growth that I see lead to? I mean, she's severely retruded with her mandible. Like everything is really super far back.
Well, so your question is, what will this lead to? Okay, well,
Yeah, if you don't fix the imbalanced growth.
Well,
I already see TMJ problems in her future.
if you think about it, right? How many patients walk into your practice and don't really have what you call a functional bite? That's not really a thing, right? Because your body is very good at adapting. People, it doesn't matter if they're super crowded up, they get the teeth together so that they can masticate their food, right? So
Right.
this adaptation process is going on. The body is very good at finding an equilibrium and allowing it to be functional. However, it's not necessarily stable, and it's very rarely is it aesthetic. Okay. So what we're doing is that's exactly what Priya's saying. You don't like it, right? You don't like the way it looks, right? And so you see the problems coming. If the upper and lower jaws are deficient and they're too far back, this lends itself to two things, correct? TMJ problems, because the lower jaw has to retrude in order to get a functional bite.
Yeah.
And crowding of the tongue, no room for the airway when they fall asleep, and now we have sleep disordered breathing, correct? So you can see these things coming. So
Totally.
what you're trying to do right now at 7 is that you and I need to talk about getting her into some therapy to get her growing in the right direction. However, you're on the right track with myofunctional therapy.
I know, but we need to come to you.
They have to have some expansion. They have to have some, and it's not just transverse. There's too many people that just want to go in a transverse direction. Yeah. You need sagittal and transverse development.
I know. It's interesting because Dr. Alex, every time we have podcasts, I know that you invite these people here for a reason because it gets my wheels turning. And I'm like, I got to get on it. So Dr. Deal, I'll be texting you, not on your vacation, after you come back.
Anytime.
Well, let's switch to airway, because this is really huge, and finally making its way more to the treatment with dentists, orthodontists. There's more conversation. Unfortunately, I don't see it much with physicians. I don't know why, but that's another thing. And what's your take on all the nasomaxillary malocclusion? What's your take on that?
Well, when you spoke of airway, and when we talk about airway's king, right?
Right.
When we're talking about the hierarchy of human needs, air is on top. There's 2 ways to get it, and that's for a reason, because you are dead in 3 minutes if you don't have it, right?
Right.
And so airway's king. So your body will do whatever it has to. It will adapt in any way possible in order to get the air. What is the second on the hierarchy of needs? It's posterior occlusion. It's getting your back teeth together, because you have to chew your food.
Right.
So your body will sacrifice basically anything but air in order to get your back teeth together. So that means painful condition, crooked teeth, whatever the case may be, poor aesthetics, whatever the case may be. You're going to try to get those back teeth together. You're going to get those back teeth together, right?
Right.
And so your question was, what about airway? Well, airway is initially how the teeth become crooked, right?
Right.
That's initially the thing. We're not chewing hard food, right? We're not developing our jaws, and that allows for a deficient jaw structure. And then we have to open our mouth because the jaws are too far back. We have to open our mouth because we can't get enough air. And so the hard diet and the air and the mouth breathing, that's how you get crooked teeth. Now, if you ask an orthodontist, and I'm not picking on orthodontists, I'm just saying, if you ask an orthodontist about malocclusion, about a bad bite, about the crooked teeth, you're gonna ask, well, what about malocclusion? They're gonna tell you it's a variation of normal, which is what they learn, and it's far from that. We've already talked about this. This is a problem that is man-made, right? We are eating soft food and we're doing too much mouth breathing. We're not developing our jaws. We don't have good craniofacial growth and development. That's why our teeth are crooked. So when we're talking about airway, when we're talking about malocclusion, they go hand in hand. Like if you expand the upper jaw and straighten the teeth and allow the lower jaw to be in a more forward position, you're going to have more tongue space and you're going to have a better airway. And that's in the literature. Mm-hmm. And so, and they just keep doing studies on how it improves the oropharyngeal airway, the nasopharyngeal airway. Mm-hmm. Study after study.
My question for you is, as a fellow with the international, orthodontist, whatever, all the things that you've done, right? Like, you've been in communication contact with a lot of different orthodontists, but sure, your views differ a lot from what they were taught in their orthodontic programs. Like,
right.
Have you ruffled some feathers? Have you been able to like?
Oh yes. Like,
turn around, Steve. We'll pull those arrows out of your back.
Right. No kidding. So, and the thing is that I think, it's more of a turf war. They don't want to see general dentists doing a lot of orthodontics. But the fact of the matter is that I treat a lot of growth and development issues. I treat a lot of TMJ. I treat a lot of sleep apnea. And oftentimes they don't want any part of any of those things. And they just want to straighten teeth, and they do an excellent job of doing so. But when we're talking about philosophy and who's right, who's wrong, I get a lot of flack.
Yeah, I bet.
And so it's not very pretty. I get teamed up on, but it's okay. I can take it. I've been around long enough now that they kind of know what I'm doing around here. At least they know what I'm doing. I know what they're doing, and everybody kind of leaves each other alone. But the fact of the matter is that you have to have a good understanding of craniofacial growth and development to do a good job with the teeth.
Mm-hmm. Yeah, no, I totally agree. And I think where my husband and I are struggling now is I am seeing patients as young as 8 or 9 years old. They are so retruded. Their jaws are actually locking shut. So right. I'm getting them unlocked. I'm putting them in orthotics. I'm watching as teeth get loose and adjusting the orthotics.
Yeah.
Accordingly.
Yeah.
But what is the next step and how do we get them there? That's what we don't know what to do. So I don't know what the next step is. So that's why we need to come to you, like either myself or my husband or both of us, ideally, but the kids are so little that I don't think both of us can come. But anyway, so that's kind of where we are, and I need to come see you.
Yeah, I mean, that's great. I will tell you that if I can get a hold of a patient at 5, 6, 7, 8 years old, that there's a percentage, and it's about a third, that their teeth, they've got plenty of room for their teeth, and mom just says that these little crooks and turns that they have, it's fine. They look fine. They're functioning fine. It's a stable situation.
Sure.
The face is nice and full. They like it, and they don't want this perfectly straight situation. They call it good, and they don't want to spend any more money. They don't want to. It's an easier way to go. But the thing is that in most cases, if they're listening and they're doing the treatment and they're paying attention to their myofunctional therapy, the big 3, that they are going to be growing in the proper fashion, as
Right.
good as we can get them. As good as we can get them. We will never make them perfect. We will never have them meet their genetic potential, because the diet is not there. The texture of the diet is not there to sustain something like that. So you are doing the best you can. Is everybody going to have room for their wisdom teeth? No, but a lot of them do.
Yeah.
Mm-hmm.
Yeah.
So
one thing I just want to touch on, and you were talking about when you expand, that the breathing is better, and talk about the relationship of the floor of the nasal cavity and the roof of the mouth.
well, that's the same thing. The floor of the nasal,
Exactly.
the roof of the mouth is the floor of the nose, right?
Right.
And so if you increase the size of one, if you expand one, you expand the other. And
Correct.
that's really where we're getting some of the nasal volume that you're seeing in some of these studies.
Right.
Now, the issue that you're seeing in some of these studies is how long is it sticking around, right? You start getting some of these 5, 6, 7 year relooks, if you will, right, at these patients, and some of it's not sticking around. Well, what is that? Well, in my opinion, and I think where the research is going to go and where it's going now is that what do we have to do to maintain this? And it's having the proper myofunctional condition.
Right.
It's having your tongue in the right place. It's swallowing correctly. I cannot tell you how important that is. If you want to tell your listeners one thing that they can do right now, it's myofunctional therapy for their kids. It is get to see a dentist who is versed in myofunctional therapy and what they're seeing, and listen to them and get serious about that, because that's the way that you make a real change.
I agree. And when my patients are done with ortho, because the whole way I'm talking about your big three, and I'm talking about their myofunctional, are you still doing your exercises? And what just really makes me the hair stand up on the back of my neck is when they're like, well, I'm done with therapy. I'm like, you are never done with therapy.
No. It's just like this. Okay, I can go to the gym and in 3 months I'm in shape.
Yeah. That's what I tell them. I'm like, okay,
but I stopped going for 3 months and I'm out of shape.
Exactly.
It's the same thing with myofunctional therapy.
Exactly.
You have to pay attention.
Oh, I drive that home so much. I'm like, you will never be done. You've been in this bad way for 30 years. Now the next 30, you got to continue in a good way. So you better do those flipping exercises.
Alex, that's a good point. It's not just kids. It's not just kids.
Yeah.
Adults need that therapy as well. They need to be paying attention to it because they can make such a difference.
Yeah.
With just that.
Yeah, I agree.
That's not like my opinion. That's been proven.
Right.
Proper oral facial growth is the way, and that's not my opinion. It's in the literature. Proper oral facial development is the best way to prevent pediatric sleep apnea. That is the truth.
Right.
That was Dr. Christian Guilleminault from Stanford who actually coined the term or did the original research on sleep apnea. He's talking about you have to have proper growth and development if you want to have the best chance of not having sleep apnea or sleep disorder breathing.
Agree. So I remember, Stephen, too, when we did a really brief exercise about opening your mouth and breathing and closing and swallowing. And so can you kind of explain that?
I think what you're talking about is where I show the power of the big three.
Okay.
Where if you want to do that, what you do is everybody just sit up straight in your chair.
Okay.
Sit up straight in your chair. You're gonna listen and then you're gonna do it. Okay. So don't be like overachievers, Alex. Okay. And so you're gonna put your lips together. Okay. You're gonna part your teeth just a little bit. Okay. And then you're gonna take 3 deep breaths in and out. Okay. So 1, 2, 3. Now, without thinking, put your teeth together. Now, where do you touch? On the front.
Yeah.
Front. That's where you touch, right? You can do it again if you want to. You touch on the front teeth. Why is that? It's because you're not with your lips together, breathing through your nose. Your lower jaw has a more natural forward position
Mm-hmm.
And so you're touching on those front teeth because your jaw is more forward. We're not supposed to mouth breathe. We're not supposed to have to slide all the way back and to get our jaws together, to get our teeth together. So it is harder to swallow with your mouth open, right?
Mm-hmm.
If you try,
Way harder. Yeah.
right? Now breathe through your mouth. Okay, you feel the muscles that you're using. Now close your lips together and breathe through your mouth. And breathe through your nose. You can feel different muscles that you use. Now swallow with your mouth closed. Different muscles that you use. This change in muscle activity, okay, is what gives the signal to the biology of growth that we're doing something different, that we need to change what we're doing. If you part your lips and open your mouth, your tongue automatically goes to the bottom of your mouth. Now you're taking in air through your mouth, even if your lips are just split. Now you are taking in air through your mouth. Well, your body recognizes this, and we say, okay, this is what we're doing. You change the entire way that you are growing at that very instant. In a growing child, they change. Now we're taking in air through our mouth. So we're going to make a change. The biology of growth is going to make a change to where we are. Now we're growing with our mouth in this posture instead of this posture. Our tongue in the bottom of the mouth versus the top of the mouth. Taking in air over the tongue versus taking it in through the nose. All of these things are signals to the body on how we're supposed to adapt. Make sense?
Yeah. It's
Totally.
just so when you sit and you sit here and you do it, and then people don't really take into consideration what the nose has to do with filtering funguses and bacteria and
Right.
viruses. And if
Right.
you're breathing
Nitrous
through your mouth,
oxide
you're
and
not doing that. Right.
There
The
are
nitrous
there are
oxide.
43 benefits breathing through your nose versus your mouth.
43? I have like
Yeah.
5. Okay.
Yeah. Don't ask me to name them all. I'd have to look it
Okay.
up.
Yeah. But that's interesting just in itself. And so many people are on a health kick or a natural kick, and they're not even breathing through their nose.
Well, and
Mhm.
even breath work as what's become popular in the
Mhm.
last 10 years, right?
Sure.
It's the same. It's trying to train yourself and trying to get more oxygen, right? The presence of oxygen is good for us. It's I think one guy online calls it the presence of oxygen is the absence of disease. I like that thought process.
I like
But
that. Yeah.
if you can close your lips and take in air like you're meant to take it, we are obligate nasal breathers. Like if you look at some of these tribes in Africa, okay, like in northern Tanzania, the Hudson people,
Okay.
they don't have words for crooked teeth and sleep apnea and dental cavities. Okay, they have wide jaws, all the teeth in, including the wisdom teeth, right? And they are not mouth breathing. They are taking in air through their nose. These are hunters and gatherers that are still chewing hard things and not weaning their kids early, and they're not mouth breathing. They are eating what we were made to eat, and their development is in stark contrast to ours. Our little diminutive jaws that we couldn't eat what they eat if we wanted to.
Wow.
It's too hard, but that is the way we were supposed to develop.
Wow. Wow, that just kind of gives you a lot to think about, because think about, well, wait until we start airdropping them food of our nature, then you're gonna start
Right,
seeing things
right,
are
that
gonna
right.
screw
And
up.
it doesn't take long, right? Like in the record when agriculture showed up. This was a study by Dr. Jerome Rose from the University of Arkansas. He's a anthropologist, and he studied an ancient Egyptian population. And when row cropping or modern agriculture showed up, the tooth wear went down and the malocclusion showed up. So beforehand, they had no malocclusion and they had a bunch of wear. After agriculture and soft food showed up, they had less wear and more crooked teeth.
Oh, interesting.
It's all about the soft diet when you're talking about how does it get started.
Wow.
Wow. Well, coming back to like balance and beauty, can you dive a little bit more into what's actually happening when we're talking about balance? Are we talking about teeth and how they come together? Or are we talking more about cheekbones and like facial structures and how someone looks?
When you're talking about balanced growth, you're talking about the bone.
Mhm.
You're talking about orthopedics, like the movement and the growth of the bone. Okay.
Okay.
Now, when you're talking about straight teeth, we're talking about orthodontics. But the bone is what we are lacking. The development of that bone is what we are lacking when we're talking about imbalanced growth.
Mhm.
And so, to be back on a better balanced trajectory, you're looking for the bone to be the maxilla to be growing more down and forward.
Okay.
The mandible to be following suit with a more of an L shape instead of growing long like this. We want it more squared off. That's a better look. It's a better airway. It's a better way to function.
Mhm.
So
More
what
room to the teeth.
are you looking for when you do a thorough clinical exam? Like, what are some markers of disharmony or a lack of growth that maybe a lay person could see, or maybe even not, maybe a dentist?
Yeah, one of the best indicators I think for altered maxillary growth, like vertical growth of the maxilla, indicating its vertical growth, is what is called the Mu indicator, and it was by Dr. John Mu, who he's kind of infamous at this point. I
Oh
think is the
yeah,
best way to
totally.
put it. So he was a pioneer, and I'm going to tell you that Dr. Mu wasn't wrong. Like
Yeah.
like his treatment, I've tried it. I can't adjust his appliance, and it might not. I don't even know if he thinks it's really a teachable thing, but he wasn't wrong with what he was talking about. Um, his indicator line that he developed, I think it was 73, 4, 5, around in there. He wrote a paper on it, and essentially it's a measurement from the left incisal edge to the tip of the nose, and it is a indication of whether or not you're growing too vertical. Now, it's not a 1-to-1 ratio, a 1-to-1 indicator. However, it is a very good tool to use to show that you are experiencing altered growth. And it's been backed up by studies other than Mu, showing the validity and the power of that indicator line. That's one of my favorites.
Hmm. You're using that a lot when you treat your pediatric patients.
Yeah, I look at that a lot on the peds, on the growing kids. When you're a non-grower, the goose is cooked. It's not there's nothing to really measure there. They're not growing, so there's nothing to measure necessarily. I mean, you can, and it will definitely, you can already see it. Flat cheekbones, long lower facial height, gummy smile, narrow arches, all of the things that we look for. And so those are usually matched with the Mu indicator in kids. That's what I use to diagnose. And then in adults, same thing. It's just the Mu indicator is not very useful
Mhm.
for the adults.
What about when you have patients that come into the office? Because this happens to me, and the mom is like, "I'm always telling them to stand up straight." And, you kinda say, "Well, it's not really their fault, they're trying to
Right,
breathe,"
right.
you know?
Yeah, in a lot
Like,
of
"Stand up
cases.
straight, okay, he's not gonna breathe well."
Right. What you're specifically talking about are the patients that we see who are even as young adults. They're TMD patients, right? And
Mhm,
they come in and their heads forward and their
mhm,
shoulders are slumped and they've
mhm,
got their butts tucked in. They got the feet walking like a duck. They
mhm,
they are just have poor posture. And mom is going, stand up straight.
mhm,
Well, these patients cannot breathe. This is why their head is so forward. And once that head gets forward, all of these other compensations happen with the body that are basically so they can walk without falling on their face. And so you want to look at mom and go, well, she can't really do it. She's
Yeah.
she's trying to breathe. That's the best way she can to breathe. So that can be really rewarding when you can get those patients sleeping better and
Yeah.
posture better and whatnot. It's not without work, though. We need the help of our allied health professionals like physical therapists and chiropractors to help us with
Sure.
those patients.
Sure.
Yeah. Yep. Yeah, we kind of do that quite a bit.
Right.
Well, I always talk about tongue position to the roof of the mouth, and where in children did this tongue position or swallowing pattern go wrong? Like, what can parents with children, infants, whatever, do to help fix this?
A long time ago, there was a study by the growth and development guru at the time, Van der Linden, and he wrote a study or did some research and showed where 50% of kids lose the proper swallow by age 6.
Wow.
Okay, so that's a tremendous
A
amount
lot.
of kids. Yes, it's a tremendous amount. This was, I do not remember the year on that study, 50s or 60s, around in there. It's a long time ago. And so, do you think that's gotten better or worse as we've gone along? I would probably
Worse.
say it's at least it's at least as bad or worse.
Mhm.
And so, when you're talking about that, that's a tremendous amount of patience. So, where does that go wrong? Between the ages of 2 and 6, it sounds like, right? And so they need to be really focused in on myofunctional therapy. When I deal with patients and treat patients who are below that age of 5, my main thing is we have to reinforce good nasal breathing, good myofunctional condition.
Mhm.
That is the key. And so like what you're doing with the myo brace, and I know that people use myo munchies, they use all these other kind of things. That's great. That's great. That is whatever you have to do
Mhm.
to get them posturing correctly with their jaw, tongue position,
Yeah.
breathing through their nose, all of those things.
Yeah. Yeah. Wow. 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 We went through a lot here, and I feel like there's still like a whole lot more to discuss.
So
And
much. Yeah.
hopefully we can get a deeper dive. And I know some of the stuff, it all goes back to the same thing, but you've got to repeatedly hear it and learn it and all of that. And Steve, I just want to thank you so much for being here.
No, I thank you, ladies. It's been a pleasure.
That's great. I just can't thank you enough, and I can't wait to get together for the study club in the fall. So that's going to be fun.
Yes,
Yes.
I'm already planning. It's going to be a good one.
Good.
Yeah,
Good.
I'm excited for either myself or my husband to sort of get started in all of that with you as well, Dr. Deal. So thank you so much. And as we wrap up our podcast, we always answer a couple questions from our wonderful, valuable viewers. So I think you're the perfect person to answer these questions with us. So
All right.
question number 1 is, will a palate expander help your TMJ problem?
That's a loaded question.
Uh-huh.
So, yes, the here's my answer to that. The problem with most palatal expansion is it does not take into account the anterior posterior, the front to back
Mm-hmm.
deficiency in most people.
Right.
This is the problem. Exactly. This is the problem, and it doesn't address it if you're just expanding this direction. That is one of my biggest things that I talk about, is that you cannot expand your way out of an AP problem, out of an anterior posterior problem. And so yes, it will help you, but you need to first be in the proper position. You have a good position that allows your muscles to be in a neuromuscularly neutral spot. And then, yes, palatal expansion will help, because that is the way that I explain it to patients when I'm in braces and when I'm in palatal expansion and all these things that I'm doing, dental facial orthopedics. I have 2 goals. I want there to be a beautiful smile, obviously, and then I want their lower jaw to close and be happy. I don't want it to be encumbered. And normally, the anterior teeth, because you just expand laterally, they're still in the way. They are not properly positioned. And there's a lot of controversy over that, but it's just the truth. If you don't deal with the anterior posterior position of the maxilla, then the mandible is never going to be in a happy place.
Right.
So,
Right. I agree. Another question. Does braces help TMJ? Been suffering with TMJ since 5 years. I don't know if that means 5 years old or for 5 years.
been for 5
But either
years,
way,
right?
it's a long time, probably.
Yeah, no doubt. Yes, braces can help when done properly. If they're done improperly, they will hurt.
Correct.
And it goes back to that anterior posterior position of the maxilla. If you can get the upper front teeth out of the way and let the mandible find a happier position, a better condylar position, it will help. If you retract the teeth in any fashion towards the throat, it's going to exacerbate the problem. This is the issue. This is the problem.
So expanding a little bit on that, the traditional orthodontics, and again, not dissing orthodontics, but the way they're taught is more retractive.
100%. Like, yes. Every single residency in the United States and across the world are teaching retraction orthodontics,
and you just said you got to get them out of the way.
You're right. You got to go wider and forward with the upper teeth. Period. When you're talking about TMJ.
Yeah, agree. 100, and I agree because I was taught by you, the real deal.
There you go. There you go.
But I did take straight wire, and I did do straight wire for quite a few years before I saw you at ICMO, and I'm like, oh my God, now I got to learn something else. And then I got on the train and start to learn. But,
this is it's true. Straight wire is great when you're talking about cosmetics. You're talking about just straightening teeth. Invisalign is great for straightening teeth. But if you're talking about trying to overcome a anterior posterior problem, you've got to do it differently.
Mm-hmm. I agree. So if there's any dentists out there that want to learn more, come to ICMO in Denver into September. Message me or Priya. We can meet up with you. We can get you in stuff if you're an orthodontist or a dentist and want to learn more. We'll get you hooked up with Dr. Stephen Deal from Little Rock, and he definitely will blow your mind when it comes to all of this stuff. So join us next episode for Unclenched, where we're going to answer questions from the listeners for a whole episode. We'll be there forever, Priya.
Definitely. Thank you so much, Dr. Deal. I always learn so much from you, and I'm excited to continue on with your Real Deal education.
Quite welcome. Thank you for inviting me. It's been great.
Thanks.